Welcome to the Creating Health Show. I'm Dr. David Haase. Hey, so we're here at the IFM hormone module, and we're here with one of the core faculty of that module, longtime faculty.
Yes.
There's Dr. Mark Holthouse, and he has guided a lot of the wholesome thinking around hormones that IFM has done a really good job of transmitting, a really nuanced understanding of hormones. And I think that's what is required, and really glad to have you here, man.
Absolutely. It's kind of my passion. When Dan first asked me to teach hormones, I said, well, I really like cardiometabolic, Dan. Do you have room in that module? And they said, no, we really need you here. So I kind of insidiously converted my talk on testosterone deficiency to men's health, and we've added prostate, we've added all kinds of crazy things and more general topics. And really, and I think he realizes now that I've tricked him. I've changed it into Dan, and you can trick Dan. That's an accomplishment. But we've really tried to draw in how it really is more of an issue with a syndrome. Mm-hmm. There's metabolic syndrome, and then there's low T, and I think it's kind of part of a sixth criteria, if you will, in metabolic syndrome as a comorbid marker for cardiovascular disease.
That's really an astounding point, because so many people want to make low T the disease.
Right.
And that, I think, has taken us down a point of separating out this syndrome so that it can be easily marketed.
Yes.
And you make it into a nice linear pathway.
Yes.
And we see clinics popping up that is just about the T. And you've really led the charge on that as a nuanced idea.
So a lot of people don't realize that only 19% of erectile dysfunction is associated with testosterone deficiency, and yet, like 50% of obese patients and 50% of diabetics have low T. So when you start looking at it, it's really a cardiometabolic issue even more than it is a sexual dysfunction. Mm-hmm. And yet, driving to work every day, I hear the radio ads of sexual dysfunction being the main driver to guys. And let's face it, that's why a lot of them, give up throw the white flag up and say to the wife, okay, I'll go see the doctor, it's over ED. So whatever it takes to get them in the office to have a discussion on how to improve their endothelial dysfunction, I'll take it. But that is really the bigger picture.
Mm-hmm. Yeah. And so endothelial dysfunction, ED, and erectile dysfunction, right? Same
ED
underlying issue.
Yeah.
ED is ED.
Yeah.
And and the penis is a huge accumulation of blood vessels. So when it stops working,
that's a great way to talk.
And so you have a great biomarker for just what is the health of your blood vessels overall, just by how easily you can get an erection, how full the erection, how long it can be maintained. That's just a vascular barometer that goes up and down.
Yeah. Well, and then so the gut people get their turn on this whole thing too. We don't want to leave them out. Cardiometabolic module is huge for this, but now I'm having to look at metabolic endotoxemia because we've got LPS, lipopolysaccharide biology getting in there, and not only screwing up the hypothalamic receptors as far as central insulin resistance now, but we're seeing that it's probably got a role to play with hormone dysfunction because there's this thing called the HPG axis. And the first of that is the H, the hypothalamus. So now I've got to think about toxicity and biotoxins too, because people like Neil Nathan and Mary Ackerley are telling me that these mycotoxins dump a bunch of cytokines all over the hypothalamus. So maybe that's related to testosterone.
Which then takes us to the immune module.
Right.
So because we're talking of cytokines and so many, I've been amazed at how many white collar men are afflicted with low T.
Right.
And how it seems to be an epidemic amongst the office workers.
Yes.
And you see individuals come in and they're so low, and the stress load, the amount of psychological stress, physical stress, inflammatory stress, impacts that. And
absolutely.
So how do you deal with this? Because there is this idea that, if you have low T, the solution is giving testosterone. And so how, when a patient comes to see you, how do you step back and help them understand the systemness of this problem?
Absolutely. So What I do is I try to take the literature and dumb it down, so to speak, distill it down into kind of bite-sized pieces. So we know all this BMI association with low T is incredibly robust. That data is incredible. So I talked to them about body composition. I talked to them about diabetes and pre-diabetic syndromes. What is it? By 2020, next year, we're supposed to be 1 in 2 of us in the United States having either pre-diabetes or type 2 diabetes. It's insane.
Everybody wants in that club.
Yes, it's insane. And it's a bad club because it's, 50% of them have low T. So I try to draw in the fact that, look, what you eat, your size, and not just your weight, but your VAT, your visceral adipose, your ectopic fat, is what's driving the leptin resistance. It's what's driving the insulin resistance. And we think that this is probably this association with this low T syndrome. So I try to have them think bigger as a low T syndrome. We try to rein in the stress that's inhibiting their releasing hormones at the hypothalamus level. We try to rein in their leaky gut issues that they've got because they eat crap. And stop drinking alcohol at night to fall asleep, because that directly inhibits your T steroidogenesis at not only the testicle, but it inhibits centrally at the hypothalamus as well. So largely, 85% of guys with low T have secondary problems. So most of these guys we're seeing have low T because of a brain issue, not because of a primary gonadal failure. And so if you realize that 89% of those people, those secondary type TDs, they have no specific medical cause. They don't fit the classic primary or secondary hypogonadal scheme. There is really a lot more to this than we initially thought. Not everyone just has that simple prolactinoma that you get the MRI and say, oh, okay, whatever, we'll deal with that. Or the simple problem with, a primary failure. So it really does cause for pause. We've got to take them through every node of the matrix. And I say this, and I said this yesterday up front, you can always tell someone that's kind of green in treating HRT because they always go for that low-hanging fruit symptom-wise and just go for the clomiphene, go for the HCG or the TRT itself right away. Because you can get all this great symptom reduction.
Exactly.
But you haven't dealt with the rest of the matrix.
Yeah, it is really taking the fire alarm out of the fire. It's ringing, so the solution is taking the battery out of the fire alarm.
Exactly.
Right.
Exactly.
We'll immediately change the symptom, but we haven't addressed the underlying cause, and then that cause continues to erode the process.
Exactly.
Yeah. So as you said, if somebody comes in, and low T has been awesome for actually getting men to pay attention to their health. To recognize that they should be vital. They shouldn't be looking for maximum wellness. That they could be expressing a higher version of themselves, being more productive in work, having a more robust sexual life, having a better mental, emotional life. And so T has kind of been a rallying cause. But that brings people in, and then for the men that understand and are curious, and I find as soon as you start to open this can, men really grab on. They love finding the cause. They feel a little bit irritated that everybody's trying to sell them a testosterone injection.
Exactly.
And instead, they know they don't want to have dementia. They don't want to have a stroke. They don't want to have heart disease. And this ED is one of the things, or just low energy is going to be part of that, making that. There's a real interesting question. So I would love to hear your response to this. So a patient comes in, and you've done this work, and you recognize it's time for them to be on testosterone. Okay, you've gone through and looked at the different nodes, but you recognize that through your analysis, this is going to be the next best step for them at this time. And they say, but doc, I've heard that causes heart disease. And that. What do you say about this? The couple of recent articles that were of questionable value. Anyway, what is your take on testosterone and heart disease?
So my take, the quick answer in the elevator is it's probably protective for cardiovascular health. And I think the best paper that I've seen that just came out, January of 18, Mayo Clinic Proceedings, we had the American Association of Clinical Endocrinologists a little known organization, right, come out and actually say about the FDA label in 2015 warning us, black box on and TRT products, that heart attack and stroke are a bigger deal. And they actually came out and said, well, actually that statement wasn't based really in any meaningful evidence, and went on to say in the same paper that in fact guys that have the best chance at avoiding metabolic syndrome and cardiometabolic untoward disease process are going to be the guys that have a normal physiologic level of T. And in fact, replacing them to get them there is probably not only protective as far as risk, but mortality, cardiovascular specific mortality is going to be less in these guys.
Right.
And in fact, the CIMT data, which is the best thing we've got to look at atherosclerotic progression, is showing that in multiple demographic groups of guys, that the ones that have optimal T have the less indication for atherosclerosis progression. So we've got dozens of papers that talk about aortic atherosclerosis being inversely related to testosterone issues, and so I think it's pretty clear if you look at the lion's share of the data that's got good methodology, that don't have women in their control groups, that
that was one of the major studies that created the black box warning.
Exactly.
It was a VA study.
Yes.
VA study that included that. I guess should we not have women in this analysis?
Right. And they relied on
horrible science,
claims data to see if somebody was actually getting the testosterone, or why they were started on it in the first place. Well, we don't need to look, right? So really questionable how a lot of this stuff even gets published. But VA study 2013. We got another one in 2013 from the NIH through the UCLA collaborative, and then the Tom study in 10. But it's just amazing how it's changed the practice format for a generation of people who never really have taken the time to look at the studies and why those things were made. And I think it was largely a response to the panic that we saw in the multi-country study on this huge 12-fold increase in sales of testosterone back in 2013. When that came out, I think the FDA just went, oh crap, we've got to do something to slow this train down, and let's just take these studies and we'll throw those as kind of a roadblock in front of this steaming train and see what we can do to buy time. Well, what time has told us, 2015, a couple of articles came out, American College of Cardiology scientific session, they presented and said, look, there is no increased risk of events in guys treated versus not that have low T. Both of the professional organizations for endocrinologists came out and said, not only is it not shown to increase events, it looks like T therapy is actually preventative, protective. And then you had the Tom study, or the testosterone trial studies that just came out with their final results in 2017-18, saying that, there was a little bit more soft plaque. We're not sure what that means, but there were no increased events in guys that were 65 treated for a year with gel versus placebo. So I think if you come at this with a preconceived idea that it's not safe and you're blinded to the current data, it's pretty easy to just march down that path. But if you're really looking at what's come out more recently by the cardiologist, by the endocrinologist, it's pretty clear. So I'm certainly doing it. And some of these guys that have prostate cancer even were using TRT in co-managing with the urology crew, and the data on that and how people have backed away from that being taboo. We once were taught beta blockers and heart failure were taboo, and now it's standard of care.
Well, and now we're realizing beta blockers have a substantial impact in dementia.
Exactly.
And whenever we're seeking to control a complex system, there's necessary blowback that happens.
Exactly.
And so, in our systems medicine and functional medicine mindset is, how do we understand the system and help it work from within? So, and when you're speaking of this association of testosterone and heart disease.
Yeah.
Not only is that what a great capsule summary. That was a very long elevator, but like the best elevator ride of my life, right?
It's to the 50th floor, sir.
To the 50th floor,
yes.
And I want to hit all the buttons on the way, because that's what I do with you if I had you in the elevator talking about testosterone. And then, but if you also then step back and say, wow, testosterone is not just helpful in its own right, but low testosterone is this marker of all this other dysfunction, which is attached to every other risk factor that exists.
Autoimmunity.
Autoimmunity?
MS, psoriasis, lupus, RA, Crohn's. We're seeing all this data now on how it modulates cytokines, and how we've got all this associative stuff. Sooner or later, somebody's going to do some RCT trials. We're going to get some causation, and then it's going to break loose, right? It's like, holy moly. So this is going to become like another subspecialty, if we're not careful. And
then the impact of stress. Anything that raises inflammation, toxicity, allergenicity is going to raise cortisol. Cortisol is going to upregulate aromatase, and then you're going to have an excess conversion of the testosterone into estradiol. And so maybe the type of therapy utilized in a particular person needs to be modified. Is it better to have transdermal? Is it better to have injectable? Is it better to have pellet? And we're recognizing that each person has their own physiologic milieu that it comes partly from their genetics and partly from the GI. That it's a system, and always stepping back and not getting blinded by a reductionist intervention.
Absolutely.
Gives us a better opportunity to help.
I think you and I can speak for you, came from that world of, we were born of the post-capitation era. We went through capitation as well, probably both of us, I know I did. And we went into the algorithmic, where you walked into the ER and now you had a pneumonia pathway, where before you actually had to think of each order that you wrote. And I understand why all that came about with not missing out on things. But the risk we took there, and I felt it even in traditional practice, was that when you checked the box and you got all of it automated, after a while you kind of forgot what orders you were writing for pneumonia care. Well, I think we have that same potential trap that we could run into with functional medicine. We're at this crossroads, and certainly hormones bring it to light, where there's this temptation for a algorithmic cookbook, one size fits all. Let's short sheet the system of learning all the different matrix nodes and just have a easy, here's what you do when this person walks in. And I think what we miss in that is the personalized care, the individualization that functional medicine has allowed those of us in allopathic care to kind of escape. And man, I don't want to go back there. I like this ability to make those pieces of that big spider web talk to each other. And there's a humility in it, because the more you learn, the more you read and study, the more you learn, wow, we don't know crap. But you know what? We know a lot more than we used to, and I'm helping people I couldn't help 10 years ago.
Right. We really are the specialty that embraces uncertainty. And reality is complex. If you want to say, I understand reality, that's usually hubris involved, or hubris or marketing.
Exactly.
And so, I have to always say this distinction between functional medicine and functional marketing. There are people out there who want to reduce it down to, either make their lives easier, because this is really hard work.
It is very hard.
It is
exhausting.
It is the hardest kind of
fulfilling,
medicine.
but
Very
hard.
And it's not stuff that enables itself to do cookie cutter.
Agreed.
But man, Mark, thank you.
Absolutely.
This opportunity to kind of dive into what creates health on the hormone side, and I'd like to really flesh out some of these other conversations we've had.
Absolutely.
Because I think the nuance is what people want to understand. They want to know that if they've done this thing and it hasn't worked, I'm not trapped. They haven't gotten caught into the blog of the day.
Exactly.
Or the guru of the moment.
Right.
Or the disease of the hour.
Don't let the
reality.
Don't let the business of this type of medicine steal the joy of delivering and practicing this type of medicine.
Absolutely. And having to fight upstream against a system that wants you to be reductionist.
Absolutely.
Everything is designed for us to be reductionist. So thank you, man. I love you.
Absolutely. Look forward to
Good
it.
stuff.
More conversations.
All right. Take care.